Tēnā koutou katoa, and welcome to this evening's webinar session. Tonight we are privileged to have Ben Harris with us. Ben is not only a medical microbiology scientist with over 40 years experience, he has an amazing ability to make the subject interesting and exciting. Tonight, Ben will take us on a journey of understanding surrounding measles, which is very topical at the moment.
Thank you very much, Catherine. Very gracious. I hope I can live up to that expectation. And I must say, I was thinking tonight, just about an hour ago, I was born on Banks Peninsula in an isolated little bay, near a school friend 6 miles away, which I had to walk to, and up 1,000 feet, down 1,000 feet. So I'm rather committed to rural. And I was also born, you may find it hard to believe, Catherine, but I was also born chronically shy, and have been most of my life. But you learn techniques to get over it. And I thought, when I was younger, if I could have ever had the privilege to have talked to multiple people New Zealand-wide at the same time, I wouldn't have believed it was possible. It's a real privilege to do so. So thank you very much. Measles, in many ways tonight, is about vaccination, really. By the time you see them, dare I say it, there's not too much you can do. Clearly, if they get pneumonia, you can. But somehow the underlying message is how, for such an infectious disease as measles, it's unbelievably infectious, then how do we get everybody? The World Health Organization would say it takes 95% vaccination rate for measles to be able to stop the outbreaks, 95%. Anyway, I'm just going to kick in. Key points at the beginning I'm going to do on measles, and then we'll go to some of the more exciting stuff later on, hopefully. So we'll just run over some of the key points for a start. So someone with measles will tend to have a cough, conjunctivitis, and coryza. So the 3 C's: cough, coryza, and conjunctivitis. I've got runny nose, but imagine it's a C there for coryza. And a fever, often quite a high fever. And then shortly afterwards comes the rash. So quite often by the time you see them, rash. And all you need to know really is to isolate them straight away. And we can't necessarily differentiate any of these rashes from rubella and other slap cheek and such like, but isolate straight away. And we know when there's epidemic going on that it is likely to be measles, but we can't actually tell until we do the lab test. And the lab test, if it's within 3 days of a rash onset, we can do the viral swabs for it, the PCR, which is polymerase chain reaction, or also known as nucleic acid test, which is the whip-de-doo new test for the last 10 years or so. It's done for chlamydia and all these other things too. Very sensitive test. So within 3 days of the beginning of the rash. But if it's more than 3 days, then the sensitivity of that test starts coming down. And so then the blood test can be useful because the antibodies start going up. So beyond 3 days, think of doing both. And further on still, the PCR test for the DNA test, or RNA test, I should say, for measles starts getting less sensitive, but the blood serology starts picking up. Always remember, incredibly infectious. So do not think, this is measles, and send them off to the nearest blood test centre if you have one, or to the nearest per-nasal one. And the same goes for pertussis or influenza and such like as well, because we put these people who may well have that really infectious disease in a waiting room with a whole lot of other people, and there may be pregnancies and such like. And we had one, I'm in Christchurch, and we had one case a couple of years ago now, of a 24-year-old who came back, I can't remember what it was from, Thailand, I think, Kiwi, came back to New Zealand, and he was ill, went in to get tested, and it wasn't glandular fever. The glandular fever test was negative, and so he was sent back for another blood test, full waiting room, to do some more tests, and they were all negative, so they sent him back again 3 times, and the 3rd time it was measles. And so there's 3 full waiting rooms, and they all had to be traced, the ideal hub and spoke. Anyway, just to be aware of that. Measles timeframes. We have the prodrome, so that's the niggling beginning symptoms, which comes about 10 to 12 days after exposure to somebody with measles. So they're the niggling symptoms, the snuffly, the conjunctivitis, etc. I'll come on to that. But that takes about 10 to 12 days until that starts after they've been exposed. And that lasts for about 2 to 4 days. There's always a range beyond that. And the rash, that starts after that at about 14 days. So the prodrome basically averages 10 to 12 days, and then the rash onset averages 14 days. But you note the 7 to 21 range, 7 to 21 day range. And the actual person, if they have got measles, tends to be thought of as infectious 4 days before the rash. So you don't know that, you haven't got a rash. So 4 days before the rash, but you can imagine your contact tracing going back to schools and such like, until about 4 days after. Some people say 5, some 4, immunocompromised is longer. So 4 days before and 4 days after. The early signs and symptoms include a high fever. It's really quite high, and they can be 4 to 7 days long. They're the dry cough, the 3 C's again, dry cough, coryza, and conjunctivitis. 3 C's. Cough, coryza, conjunctivitis. And these things called Koplik spots, which, if you can all see it on the screen, the little wee white spots in the mouth. That suddenly does become very diagnostic, really, that it will be measles, or high up the list of probability that it will be measles. Then the rash itself, which appears 2 to 4 days after those initial prodromal symptoms, and that fades after about a week, and the patient themselves feels worse on the 1st or 2nd day after the rash develops. They feel worse then. And the rash, you can read the description of it there. So we can't tell many rashes in children, and so we can't know for certain that it's measles, but if it's part of an outbreak, then of course, of anything, then of course it's likely to be. Unlike chickenpox, which is more diagnostic. Chickenpox is very, very clinically characteristic. Complications, interestingly enough, they tend to be in the under 5-year-olds, the significant complications, under 5-year-olds and the over 20-year-olds, under 5 and over 20. You tend to think, oh, it'll be any children and not the older, but under 5 and over 20-year-olds, and anyone with immune deficiencies, etc., are going to be worse. Pneumonia is one of the most common complications. And incidentally, I did look it up before, I can't remember, it's about 160 cases of measles in New Zealand being reported up to May this year, something like that. I should look it up again, I've got it written down in my book, but it doesn't matter. And something like 38% of them have been hospitalized. So just think really high rates of hospitalization. And otitis media and such like are all common. So the pneumonia can be from the virus itself or a secondary bacterial infection, because the measles virus suppresses our immunity, which makes us more likely to get these other bacterial infections as well, and or with the measles virus itself. About 1 to 3 per 1,000 patients develop acute encephalitis. Acute encephalitis, and that can be brain damage, and it's fatal in about 10% of them. So there's really quite high associated death rate with these. The vaccine efficacy. 1 dose, about 93% effective. 1 dose. And I've just slipped for your own interest the mumps efficacy and the rubella efficacy. Notice how high the rubella efficacy is. But 2 doses of MMR is 97%. That's what we'll be aiming for. Remember, WHO said we need at least 95% vaccination rate. So we really want that two dose to come in there. And remember, it's a live attenuated virus. The initial vaccines were not live, and they didn't work as well. So now, since 1969, basically, we're using the live virus, attenuated virus. Don't use it during pregnancy, but it's all right while breastfeeding. And it takes, similar to influenza vaccine, takes about 2 weeks for the full immunity to develop. Just remember that 97 out of 100 efficacy still means 3 per 100, even if they have been vaccinated, can catch measles. So 3 per 100, even of a fully vaccinated population, will still come down with measles. 3 per 100. Post-measles exposure, so long as the person's not pregnant, within that 72 hours, there may be some benefits in giving the vaccine, MMR vaccine, and or there can be benefits in giving the immunoglobulin within 6 days of exposure. So just consider those two. A little bit like hepatitis B. If someone's exposed to hepatitis B, if they haven't been vaccinated, there's still value in giving them the vaccine straight away, within a day or two. Onwards, I've tried to lay out the clinical course on this. This is a clinical course, so it's not the incubation period, that's 10 to 12 days before that. And we can see the febrile on the top, dark blue there, the febrile day 1 of the illness, so after it's had its 10 to 12 days incubation. And then you can see the conjunctivitis and the cold-like symptoms coming in on that day 1. And then maybe a cough coming up after that. And the Koplik spots come up a little bit after that again in the mouth, the white Koplik spots. And then the rash comes just before the peak of the fever. Rash comes just before the peak of the fever. And I can represent that different ways. I'm not sure if it's easier to see. I'm not sure if that helps or make it harder. So on the top line there, you can see rash onset or exposure, 2 different lots of figures. So we have the temperature coming in and cough, coryza, conjunctivitis, Koplik spots a little bit later, and then down the bottom in the red, the rash. And so just the rash starting at some time after. And if I slip in on this one, if you've got that slide in your mind, and then I put in the serology and PCR or NAT test, so you'll see after the rash, the serology, the IgG, IgM, starts coming up after the rash. So that's why we mentioned earlier on that NAT or PCR test is good before the rash starts and while the rash is there, but then it starts dwindling down a bit when the serology antibodies start coming up. So leave that on for a second to absorb that. And this is the antibody responses. So the antibody response, see, it takes a little while. I'm sure you're all well aware, and I'll just re-emphasize, IgM for most infections doesn't last long. So it comes up and it doesn't last long. So if somebody has IgM for something, it means they've either got that disease now or they probably haven't had it very long ago. So they're just so it comes up early on and then it fades away. That's typical of the IgM for many diseases, infectious diseases, whereas the IgG tends to come up and it can stay up for a long, long time. So one blood test that's IgG positive with no IgM, you're not sure if that's from vaccination or previous infection, or if the titer is falling quite rapidly, you might think, that's indicative of recent past as opposed to a stable IgG, just to be aware of that. And you'll see 90% of measles cases are IgM positive at 3 days post the rash onset. So it's coming up to 3 days after the rashes start. You'll probably get at 90% at 3 days. And IgM levels peak after about 7 to 10 days, then decline rapidly. Okay. Why is measles so infectious? 90%, according to CDC, 90% of people that have close contact with somebody with measles who are not immune, remembering 3 out of 100 who have been vaccinated, not immune, if you like, they're liable to catch it. So 90% of people who are not immune will become infected. Why is this? And I'm going to, for those of you who saw the influenza talk I gave, it's been about a year ago now, I'm just going to go over this again because it's the nitty-gritty of these things. An infectious dose or an infectious number threshold. So I always say there's no such thing as good bugs and bad bugs. Milk bottle bugs, freshly delivered litre of milk, we can drink that milk. It's been pasteurized, not sterilized, it's been pasteurized. We can drink that milk. There's hundreds of thousands of bugs in there. We drink it and it keeps our immune system fit and healthy. Our immune system just goes along and neutralizes those hundreds of thousands of bacteria in that pasteurized milk. We don't get ill, so we tend to call those good bugs. But if that litre of pasteurized milk has been sitting in a cupboard for 6 months, we may be reticent about drinking this stinking, clotted, fermenting mash, and we'd have good reason to because it would make us ill or could kill us. So the infectious dose, or the infection number threshold for milk bottle bugs is something like over 1 million per mil, over 1 million per gram. Virtually every species has its number that we can't control. Yogurt has an incredibly high number, but if somebody has a autoimmune illness or lowered immunity, then even yogurt can kill them. So everybody can, there is an infectious dose. Salmonella is about 1,000. More than 1,000 will get clinical infection. Less than 1,000 salmonella will get immunity to that species and will have no symptoms. If we're to take 1,000, this is the average person, if we're to take 1,000, we may have a bad biorhythm day, just be feeling a bit off colour but not know why. Then influenza is about 800 we have to breathe in. Seasonal influenza at about 800 influenza virus before the average person is likely to succumb. Campylobacter 500, Staphylococcus E. coli. Now, norovirus 10 to 20. More than 10 to 20 virus, we will get norovirus, diarrhea and vomiting. That's why norovirus is so unbelievably infectious. But we don't have a vaccine for that. And the immunity to norovirus only lasts about 3 or 4 weeks, and then it's gone. Measles, though, it has an infectious dose of 3 to 10 viruses only. So norovirus is 10 to 20, and we know how infectious that is. Measles is 3 to 10. So way less than norovirus even. So that's the infectious dose part. Of course, it makes a big difference how many are there at source. So norovirus, for instance, there are 1,000 million viruses per tiny gram of feces or vomit. And when it's steaming, 1,000 million to a tiny wee gram, then of course we're likely to breathe 10 to 20 in the case of norovirus. But measles, it's only 3 to 10. Then the next thing, coupled with that infectious dose I wish to look at, is, as I've just said, we have the, on the left here, we have whatever it is, the red line of the microbe, virus, for instance, norovirus or measles, starting to increase, but the green immunity stops it before it gets to that bright red line, which is the infectious dose number. And for measles, that might be 3 to 10, norovirus 10 to 20, influenza 800. That makes sense? Once it gets over that red line, the infectious dose number for that particular species of virus or bacteria, then we have clinical infection. So subclinical, we don't have symptoms. That's when it's under the line. When it goes over the line, we get symptoms. So that's another key point to know. We can catch, so-called catch the infection, but not have any symptoms. But we usually develop immunity. Now comes something called the rho value, and this puts the other two together. So if something only takes 3 to 10 virus for us to breathe, then out of a group of people that are not immune, as the CDC says, Centre for Disease Control says, 90% of them are going to succumb if they're not immune, because In other words, on average, that row value, R naught var, is a reproductive number. The average person with measles in a community that is not immune will infect 12 to 18 other people. 12 to 18 other people, which is huge. And that's partially helped by two things. One, the really low infectious dose, 3 to 10, but also that it's airborne. This virus will fill a room. So if I'm coughing and it fills the room with lots of virus, but you only need to breathe 3 to 10, that's why it is so unbelievably infectious. The seasonal, a row value for any infectious disease, if it's higher than 1.0, then on average somebody with the infection will infect one other person or 1.2 other people or 1.3, but in the case of measles 12. And when the row value drops below 1.0, so that's 0.9, then that outbreak will come to an end because we're infecting less than one person on average. Does that make sense, all right? Hopefully. Hopefully it does. Out of interest, so the 1918 pandemic flu influenza, which killed 50 million people in the world, 1918-19, just over 3 months or so, that's row value was 2 to 3 only. Measles 12 to 18. I just can't emphasize it enough, that's all. Just keep laboring on that. Whereas the seasonal influenza is only something like 1.1, 1.2 for a while until it drops back to 1.0. Ebola, incredibly infectious, but only if you have that person's blood going through your broken skin. So we catch it the same way as we catch hepatitis B. And so it's never going to be an issue essentially in the Western world because we've already learned to mitigate the risk from that. I just expand on that. Somebody with influenza coughing, you'll only have 800 virus. I'm glad you can't get wet as I cough. You'll only have that 800 virus within just over a meter of that cough, just over a meter. The influenza virus itself, because it's tiny, will actually fill the room, but not at a level of 800. So only the 800 is within a meter. And that's why a mask will even stop those large droplets with the bulk of the influenza virus in them. But even an N95 masks only stops 95% of particles down to 0.3 microns, which is a small bacteria. And viruses are 100 times smaller than that. So the virus, when it's not in a droplet, will whistle through even an N95 mask. So what I'm saying, for influenza on the right-hand side of that cough there, the influenza will not be present, the red dots will not be present in a dosage of 800, but measles will be present in 3 to 10. And an N95 mask may reduce your chances. If you're face on to the person, they gave a wet sneeze in your face, it'll reduce the numbers. So it's going to help, but it's not going to stop. It's going to help. It'll reduce your chances, but not going to stop. Okay, which is why I put this poster together with anybody with a new cough. If we want to change the whole culture so people do wear a mask, this is thinking of winter coming up with influenza. So we wear a mask. If everybody, most people with influenza just have a cough. Most people are not febrile, do not have run over by the bus syndrome or anything else. Most people with influenza, 90% of them, just have a cough which cannot be differentiated from the other 18 or so respiratory viruses. But we don't want any of them. So wear a mask, even if you're a healthcare worker and just have a new cough to you. It's not your usual allergy or COPD. Just have a new cough, perfectly well enough to work. You think you certainly haven't got influenza, you actually do not know. So wear a mask and have your patients do so too. So I said this whole talk is about vaccination in many ways because we have failed collectively when patients come in. So we take 100 people, 100 people, and so if they are all vaccinated, 100% of them are vaccinated, remember, it's 97%, 3 will not be immune. So if one person on the top right has measles, for whatever the reason, then it's quite a trouble for them to find those other 3 to pass it on. So it's quite a trouble. That's why the outbreak tends to burn itself out. It's not very likely. But if only 93% were vaccinated, then 10 are not immune. 7 from those that were not vaccinated, plus another 3, because it's only 97% efficacy if they've all had, then suddenly that red person top right with the measles can relatively easily pass it on to the next. Remember, on average, it's 16 or so people pass it on to if they're not immune. And that's why that tiny difference, 93%, 95%, 90% vaccination rates, for something with such a high row number or R0 number of 16 or so, why it is so infectious. That would not happen with influenza, but it happens here. Does that make sense? And I've tried putting this together in various ways. This is another one. So the blue is not immunized but healthy, and the yellow is immunized and healthy, and the red are those that are ill and or contagious. So in the top one, nobody immunized, but if there's 1 or 2 in that whole group, then of course on the right, most of them come down. If not so many are immunized, on the left, then a large number are still going to come down. That's in the middle one. But on the bottom, if there's a good number that are immunized, then we have a major effect on being able to pass it on for outbreaks in a population. Does that help? Just saying the nitty-gritty of it. Okay, this is another interesting one. I just like it. If the vaccine efficacy is low, for instance, influenza vaccine, it's only maybe 5 to 50 or 60%, depending on age and the year. Low vaccine efficacy. If there's a low vaccination rate, then of course there's no herd immunity. If there's low vaccine efficacy and a high vaccine rate, there's still no herd immunity. Because if you can't get it up because the vaccine efficacy is not that good, you can never get a significant number of the population protected. If the vaccine efficacy is high, like measles, then a low vaccination rate is going to be no herd immunity. But if there's a high vaccine efficacy, as with measles, 2 doses, and a high vaccination rate, then we get herd immunity. But it all depends on the row value, how many people the average person would infect, which in turn depends on the infectious dose and the transmission rate. So how are we doing in New Zealand? This is the latest data from MOH, and I'm just trying to skim through. Thank you, some of the good comments coming in. Have to leave, sorry, one, brilliant, thanks. And someone said there is a link to the YouTube via www.nnz.org.nz. I'm not sure if that helps any of you make contact. Sorry, I've got to leave. Welcome. Remember to change setting to all panelists and attendees. That was for all. Yes, change to all. All right. Now we're on, I think. So we only got up to about 93% vaccine. It's not bad. That's on first dose. That's across the different DHBs, fairly much the same. A couple of laggards there. 2006, 2007, that was around the 90% for the second dose, but we need to actually get to that 95%. We need to get to the 95%. So it's a small bit, but it's a critical small bit. And out of interest, the ethnic breakdown there. So New Zealand European of interest. The Maori were higher around 2006, 2007, 2008, 2009, and 2010. They were higher than European. So it's good to see. There must have been some really hard work done, because it's so often not the case, as you'll all be well aware. Where did I suddenly jump to there? Second dose, ethnicity, 29. I'll try 29, 27. I was going to do 28. What was that one? I've got far more slides than I need. Yep, we've just done that. So, note, and these vaccination rate informs the measles rate. So in the UK, there were 14.4 cases of measles per million people when they had a vaccination rate of 92%, 14.4 per million, while in Serbia they had 640 per million when there was an 86% vaccination rate. So very, very slight changes get really magnified a lot in something that's so infectious, such a high row rate. And there's another interesting thing, well, I think it's interesting, so I have to make sure you do too, with vaccination rates, and that is populist politics. And this has been written up, European Journal of Public Health, and the populist politics and vaccine safety beliefs. So note, as more people start voting what's often right-wing, but not necessarily left-wing also, populist parties, the Trump parties, if you like, and as more people start voting for them, they tend to be people that don't believe in vaccines. So we have the likes of Andrew Wakefield, Dr. Andrew, well, previously, former Dr. Andrew Wakefield, who was struck off the register, who published in 1998, I think it was, on the Lancet, about the link to MMR and autism. And that's still quoted on the internet, even though he admitted it was a complete fabrication. And so he is struck off the register. That paper was withdrawn. Unusually, you can write controversial papers to medical journals. That's good to challenge science. But when it's a complete fabrication, was struck off. And that's still quoted by the anti-vaccine lobby. And Trump's inauguration, Andrew Wakefield was invited to the inauguration as well because of his linked autism to just unbelievable. If people are wanting to find something on the internet, they will, and somebody clearly saw there's votes in it for them will get that lot as well or bring along. Anyway, the vaccine hesitancy, as the WHO call it, comes from a profound distrust in elites and experts. Profound distrust in elites and experts. That's why they are following through populist parties. And it's difficult to resolve this distrust unless the underlying causes are addressed, which tends to be those people that go for populist causes tend to be political disenfranchisement and economic marginalization. So those that think, listen, I don't trust them, they're so-called experts, whether it's medical or political or professors or anything else, I don't trust them. They haven't helped my life at all. I'm at rock bottom, and anything's got to be better than that. So I'll vote for somebody that promises the earth. That's the populist party. So those tend to tie in somewhat. I think it just helps understanding that. The WHO, if you're interested, have written a, I read it last night, 50-page booklet, it's online, on vaccine hesitancy and how to address it in public speaking. So it's down the bottom right there, the name of it when it comes through in PDF at some stage. So a hesitant individual, with the right approach, you're likely to be able to bring them around to vaccination. A vaccine refuser, there's a low chance, but with the right techniques, you can do it. I've done it many times, I might add. And that includes stories of cases you've known where people have been the storyline, people you've known who have died or been permanently damaged. And I use pertussis cases where people have been, the babe is dead in the mortuary and the parents did the right thing, what they believed was the right thing, and didn't vaccinate the child and the child died. I've seen several of those, and the parent, when they ask and pin you down, can you tell me straight, say your child would have been almost 100% definitely alive if they'd been vaccinated. But the very vocal ones in a group, they're unlikely to change. But there are a number of techniques you can use. We tend to follow, I think New Zealand, maybe not many follow Trump, but we tend to follow leaders. And of interest, we're fighting against Gandhi, who was a well-known person, and he didn't believe at all in vaccination, as it happened. So, and when vaccinations first started, there were all these cartoons written. You can see some there somewhere with snouts coming out, pig snouts coming out, and all these dreadful things that the vaccinations do to you. So maybe it's a good thing. I can't see, because some of you may have grown all sorts of things coming out of you after being vaccinated. We know they're rubbish in many ways. I'm just going to take the time, this isn't on measles, just to go through very quickly, and you'll say it comes. TB new cases, about 10.4 million new cases a year. We're talking about infectious diseases, of course. 10.4 million new TB cases per year. We have about 200 to 300 in New Zealand new cases every year. 500,000 develop multi-resistant TB every year, leads to 200,000 deaths. Multi-resistant TB, tuberculosis, which is a bacteria, like measles, is airborne and fills a room. Like measles is airborne, although TB, you tend to have to be in the same room as somebody with TB for about an hour. Measles, not nearly so long, but some of the important things are, and where is TB most found? Though on the left, 22 high burden countries, and on the right, all those countries that have had multiply resistant TB found, including New Zealand. So yeah, it goes, aeroplanes go around the world. But what I wanted to show, which with these infectious diseases, it made TB as airborne, so is measles. So there's a correlation shown between TB mortality per 100,000 and how many windows that person had in that house. So measles, with an airborne virus, if you've got a window that opens outside, if you open the window, it will dilute out the air inside the virus in the house, just like TB. Isn't that interesting? Anything that dilutes the air, will reduce, more air changes will reduce the virus particles in there. And similarly, rooms without direct daylight, there's a direct correlation with TB. So maybe the daylight kills the TB, and it quite likely kills the UV light, quite likely kills the measles virus too. Measles virus, unlike TB, will die relatively fast. So a room, RNA virus, but a room will generally be infectious up to 2 hours after somebody with measles has been in it. Up to 2 hours. That's why you don't send them to another consulting room. Up to 2 hours. After that, the air will have just changed naturally, and a large number of the measles virus will have died, or at least have settled, say, on a surface in a cough, and you're not going to be able to breathe them very easily. So the risk goes down dramatically after a couple of hours. Other vaccine naysayers of people just against vaccine, you always get them to look up the internet or look at things like this. Diphtheria cases, vaccine introduced, look what happened to the diphtheria cases. Chickenpox, varicella, when the vaccine introduced, goes down. Pertussis cases, DTP introduced, then the others introduced, look how it went down. And polio deaths, vaccine. So anyone that has doubts, you can show, can you try and explain some of these figures? I've just put this one out of interest. I don't know if you've seen it before. I may have shown it on the influenza one, I'm not sure. In the late 50s, early 60s, Japan got hit really hard by a new strain of influenza. So a high death rate, really hit hard in Japan. And so a vaccine was developed, and they made it compulsory for children. All children, they made vaccine compulsory. And look how the all-cause deaths just dropped down. 20 years later, the population started doubting, why should we compulsorily vaccinate our children? So 20 years later, the public pressure became so much that compulsory vaccination in Japan for children was stopped, and look what happened to the vaccine, to the influenza rates and the all-cause mortality. In some ways, a surrogate control, it wasn't a formal control, but when they looked at the United States all-cause deaths, even though they were vaccinating all over 65-year-olds, it didn't change at all. The message actually is, backed up by lots of other data, which I've tried presenting to Pharmac and to MOH, is that if we were to vaccinate all under 16-year-olds for influenza and no over 65-year-olds, we would have something like a 65% efficacy in the over 65-year-olds, rather than the current 5 to 25%. But it would take a major mind change to change it, and there's plenty of things to show that and prove it. So measles, as that's what the talk is about tonight, but just tying it in with those other vaccine ones. Incidence and mortality. So the incidence along here, so from 1912 through till 1967, and the death rate and the solid bar down the bottom. And then when we come through from 1912, here we go, the inactivated vaccine was used for a start, 1963, and then the live measles vaccine, this is in the States, started, so that worked a lot better than the inactivated one, the live vaccine. And in New Zealand, we started in 1969. Just remembering, prior to 1969 in New Zealand, there's measles going throughout the community the whole time. And so, because 16 to 18 others are infected by anyone with it, then everyone's exposed. And everyone will either get it clinically or subclinically. So any one person in a school has it, it's going to go through the whole school and everyone goes to school. But after 1969, once we stopped it in the community, then people are not going to catch it naturally in the community because we've stopped it. And so then it's even more important to be vaccinated. And in case people think, isn't natural immunity better for you? Shouldn't we have these chickenpox parties or measles parties? Yeah, it's not bad. You just have to explain to the parent the 1 to 3 per 1,000 who got brain damage or died. That's just part of getting natural immunity, and the pneumonias and the 30 to 50% hospitalization rates and everything else. So at the time, there's an element of sense to it because there's no alternative. Might as well get this over and done with. But when there's alternatives, don't even think about it. That's the sort of talk you need to anyone that's talking about that sort of thing. It's a realistic death rate. Yes, there may be a significant adverse reaction from any vaccines, including measles, maybe 1 per million, as opposed to 1 per 1,000 brain damage, encephalitis, 30 to 50% hospitalization rate, pneumonia, and all the rest of it. It's trying to get the perspective of that happening. Okay, so I think the questions that were sent out earlier, I think you may have got them, I'm not sure. Can the fully vaccinated still catch measles? Yes, 3%, 3 in 100. When was New Zealand measles vaccination introduced? 1969. Other countries, it will be different. And remembering, if you're not vaccinated, and you go overseas to a country that has low vaccination rates or none, if you get it as an adult, the under 5s and over 20s are much hit harder, much worse clinically. So you may get away with it here, but you're unlikely to if you go overseas, and it's going to hit even harder. I had a case in Christchurch because we've finished epidemics for measles in New Zealand. They're always going to be relatively low numbers because so many are vaccinated. And for instance, I had a rest home manager phone me about 3 months ago. Oh, should I be worried? I said, if you get an outbreak, the absolute most you're going to get is 1 to 2 cases. It's highly unlikely to be in the elderly. You may get 1 or 2 in your staff at most. But remembering different countries, if you've got people from different countries, they may have different. And one person in an outbreak we had who had contact was from Germany, and she was a child around the 1970s, early 70s, and her mother said she'd been vaccinated for everything, but she didn't know if she'd been vaccinated for measles or not. Her mother, when she contacted her in Germany, because she'd had contact. I actually looked up Germany to see when was the measles vaccine introduced there. And once again, there's often interesting stories when you look up. East Germany, authoritarian, thou shalt get vaccinated. Full stop. 100% compliance. East Germany. West Germany, we encourage vaccination. And it took a longer uptake. So it depended on where they came from. East Germany, 100%, and they wiped out the measles. West Germany, not so authoritarian, and they had more measles cases, and it didn't become more prevalent, the vaccine, until later on. So they're just always interesting things like that when you do look up. What are Koplik spots? We've covered that. And the mouthful spots, incubation time, we've covered. When is someone with measles infectious? 4 or 5 days before, 4 or 5 after. Highest mortality under 5/20. Even on the far side of the room, yes, it is airborne. Yes, it is airborne. How effective is PPE? Wear it, but don't rely on it. Full stop. Face-to-face contact is going to be a higher concentration of measles than at the end of the room. And face-to-face with spray coming out of a meter, plus all the tiny little droplets, you're going to have a high chance of getting it, very, very high. You're going to have a lower chance at the end of the room. But those yucky wet droplets, you don't want them. Measles parties we've covered. Measles antibodies, does it guarantee immunity? Well, you can't give more, but it doesn't guarantee it. There's not enough data to know if you have antibodies, do you definitely get it. Now, I'm just going to look back some of the comments that have come in. You're right, I'm a child of the 70s from East Germany. Well done, you'll be immune. Judith. Marie, interested in your comment about patients with influenza only really having a cough and not aches, etc. Whereas sentinel practice, so do the swabbing, and from what I've seen, the fever and aches are more problematic than a cough. So really good point. Sentinel practices, this is really important for influenza. The surveillance criteria, WHO and CDC, so New Zealand adopts those for influenza, is you must have a temperature, must be febrile, 37.8 or higher, plus a cough and or a sore throat. That is surveillance criteria. Now, if I just spend some time on that, surveillance criteria is much tougher than actual clinical likelihood. So surveillance criteria is not used or should not be used to diagnose all patients with influenza. It will only find about 10% of them. Surveillance criteria is used because it is harsh, so we can compare this year's influenza rate in the Hokianga compared to this year's influenza rate in Stewart Island. It is not to say how many actual cases, it's indicative of how many cases are around. If you were to surveillance criteria all those that had the febrile, cough, sore throat, you may have about a 60% positivity rate, 60% positivity rate. Whereas if you're to test everybody and you'll miss 90% of the influenza actual cases, if you're to swab everyone with just a cough, then only 10% of them will be influenza, but you'll detect 95% of all influenza cases. Does that make sense? I hope, Marie. So surveillance criteria, stick with it, must have a temperature, plus cough and or sore throat. But all the studies, including the Shivers study in New Zealand, shows that is the tip of the iceberg only, surveillance criteria, as opposed to clinical criteria. And brilliant, thank you. No one swore at me yet. This is linked to YouTube. Okay, that's great, thank you.
Ben, there's one on the question and answers forum as well from Julia. She's asked, how well covered are children under 1 year?
The first few weeks, they have mother's immunity. They're not so well covered. And then there's never going to be any controlled trials on this, I might add. So we have trouble getting the data in the industrialized world, because on the whole, vaccine rates are quite high. And because it's a live virus, when the child's immunity is not so good, it's not normally given to them until they're older. So we have to protect them even more over that vulnerable time. However, the United States criteria would say if you're traveling overseas with an under 1 year old, you can vaccinate them at 6 to 11 months still. That's the CDC criteria. But I'm saying follow the New Zealand MOH criteria, but it's because of the live virus that there are the troubles. And so it's a careful balancing act, and there's no guaranteed right answer except follow the local guidelines. Will save you end up being in court, but there are different interpretations of that along the line for those reasons. You'll get some of mother's immunity for a while, but then that'll peter off. Best anyone with a rash or ill, don't let them there, babe. And so I hope that covers the question for the person that asked it. Thank you for asking. Any others come in? So
yeah, we've got another two just popped up. You've started them now, Ben. So on your chat one, you've got, do you know why the 3% who do not gain immunity from the vaccine happen?
Really interesting question. Actually, and I've done a lot of reading on it, trying to follow, and nobody knows with any certainty. Part of it may be some people just do not develop the antibodies, but we're not sure if that's the reason or not. And part of it may be that there's two main forms of immunity. I'm going to come back to hepatitis B again. Two main forms of immunity. One is humoral or antibody immunity, which we can measure in a blood test. So for instance, hepatitis B surface antibodies. And in the case of hepatitis, they come up after vaccination, then they tend to drop down over 8 to 10 years and disappear. So we used to revaccinate again. But we now know that not one of those people who was fully vaccinated to hepatitis B, even if they were one of the 7% that did not develop measurable antibodies to hepatitis B, not one of them went on to get clinical hepatitis B, even though they were subsequently exposed to hepatitis B for a cut from a known positive. So there's humoral antibodies that we can measure and go, but there's also another degree of immunity called cellular immunity. And cellular immunity, other than in research situations, we cannot measure easily in a laboratory. So in the case of hepatitis B, the antibodies come up and go down over 8 to 10 years and disappear, but we still have immunity. So in that case, it must be the cellular immunity that carries the day. But nobody, from all the reading I've tried, actually hours and hours on it, there's not enough data to definitively say, is it somebody that did not develop measurable antibodies or not for measles? Really incisive question, thank you. Any others?
Yes, thank you. You've got another one. This is quite an interesting one. It says, hi, Ben. So this is on your chat as well. You might want to read it because it's quite a long one. But it says, hi, Ben. I have a very random question.
Okay, yeah.
You spoke earlier about how opening a window will dilute the measles virus. Then, in theory, if you run a long-haul flight, it is wise to point the aircon vent at yourself, create a positive pressure. And does the HEPA filters in the plane do anything?
I'm glad you didn't say, should you open the window by putting your elbow through it. That would certainly dilute the virus out. I don't know that anything has been done specifically on it. I suspect the HEPA filter would not filtrate the virus because it is tiny, 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 but that there may be enough air volume from one person with measles, gives a cough, lets out several hundred virus. By the time it gets into the air conditioning, I think it may well get diluted out too small. The biggest risk is going to be from that person within a metre or two of you. That is going to be a bigger risk, probably no matter where you point the air conditioning, the air conditioning in the plane. So I hope that covers that. Does the vaccine contain component from fetuses? No, I don't. Well, specifically, I don't know, but I would be astounded if it does. I was asked about this from an anti-vaccinator. Sorry, I'd have to specifically look back, but I would be absolutely astounded if it was, and I could virtually guarantee it's not, but I can't actually guarantee that. I'd be truly, truly astounded. And I think that is a case sometimes you get, I heard. it wouldn't make it, I'm sure. It would never make it. Carrie, that's the exact question I posted on Quora a week or so ago. Okay, about the fetus, I presume, rather than the airplane filter. Either or. Airplane filter, I wouldn't worry about it. If you wear it, you've still got to breathe, and so if there was enough virus coming out of that air vent in a plane, even if you didn't have it on, it's going to be coming out from the person next to you, and whether you've got it on or not, you're still going to breathe it. I don't think there'd be enough there usually in that. Okay. Oh, how long does vaccine immunity last? Is it lifelong? Yes. Or are boosters required through? So for measles, thank you. Measles, you have the 2 full vaccines that last for life. Or should I rephrase, you've got a 97% chance of having immunity for life because 3% fully vaccinated seem to still catch it. Okay. Right. Any other questions there? Where did measles come, or has it always, excuse the pun, plagued humans? Now, I've only got a few minutes to do this, so I'm going to rattle through it. And it comes from the rinderpest virus from cattle. Rinderpest virus in cattle. That's the short answer. That's where measles comes from. And I know one of us has got an itchy eye, so I hope it's not prodromal conjunctivitis. And the rinderpest virus, I'm not going to read all that out, but it used to kill millions, hundreds of millions of people over hundreds of millions of cattle over hundreds of years. So caused mass famines because suddenly all the cattle were wiped out in Africa and spread far and wide. 80 to 90% mortality rate, this virus. And the last recorded case in cattle was 2001. It was vaccinated out of cattle, and the world was called rinderpest virus free in 2011. So that's only the second disease in history that's been wiped out. Smallpox and rinderpest. We're very close to it with polio. It's down to about 30 cases or so between Pakistan and Afghanistan, 1 or 2 cases in New Guinea. So until we get those last cases out, same as smallpox, we won't be able to rid the world of it, and it could come back very, very fast. So that's in cattle, first recorded in 376 AD. Now I'm going to take a different tack, and so that's the rinderpest virus, masses down, they had postage stamps, so it's just such a dreadful, dreadful, dreadful wipeout, but it's now the world is rid of it. What caused most infectious diseases? I'm going to go through this fairly fast. What caused most infectious diseases? Because I find it a fascinating story, so you're going to have to too. So the Earth formed maybe 15 billion years ago, and not the Earth, the solar system, then universe, and then 4.5 billion years ago, 4,500 million years ago, it's believed, I'll say, because some people have taken me to task with religious reasons, 4,500 million years ago, it's believed by scientists that the Earth started. 1 billion years ago, the first bacteria started, so they've been on Earth for 3,500 million years. They're the ultimate survivors. Whatever temperature, gases, sulfur dioxide, chlorine, 1 billion years they had no oxygen. They survive anything. So another billion years with oxygen. Then the much larger eukaryotic cells, human and plant cells, came about 1.5 billion years ago, 1,500 million years ago. The so-called Cambrian explosion has only occurred in the last 500 million years. And that's when all the different species of animals and plants and such like evolved, just the last 500 million years. But we've got the common ancestor, and just for the record, every eukaryotic cell has mitochondria in it, which was originally a bacteria, and we even know which bacteria it was Rickettsia. So we are integrally related to bacteria on a cellular level. Those mitochondria give every one of our cells energy. And on top of that, we've got bacteria all around us. Anyway, so we have co-evolved for us or our ancestors, 1,500 million years, there's humans just that tiny little bit up there, co-evolved with our bacteria in our gut. So the vertebrates have a gut, and that's called the holobiont. we are effectively a multi-species animal, and we require this mass of bacteria, this mass of organisms. In fact, when we've got the full complement, vaccines work better and our immunity work better when we've got the full complement of those bacteria. So all humans have a touch, whether it's bacteria or eukaryotes or animals, we're all a mishmash. We are, you are us, if you like, you are us, and we're talking to the bacteria, to use the common expression going on at the moment. And we know there's a degree of dog eat dog in Darwinism, but there's also symbiosis. As I said, even the bacteria in every one of our cells and all our gut bacteria, which maybe have up to 10 times as many cells as our own human tissue cells, but each one of our tissue cells in turn has mitochondria or ancient bacteria, rickets in it. Then, remembering we're frail little petals, and the 5 mass extinctions only happened in the last 500 million years with relatively small changes in the environment. Much bigger changes before that, bacteria survived a lot. I just say that out of interest. Humans were hunter-gatherers. And with hunter-gatherers, we needed a lot of space to get enough berries and fruit off trees to survive. And when we'd run out, might be 15 to 20 people, when we'd run out of those fruits and berries, we then had to keep moving through the forest. We couldn't settle because there weren't enough fruits and berries. What I'm saying is there might have only been pods of 10 to 20 people living in a cage. Now, they're relatively isolated because they're competing against another tribe trying to get the same food over the hill. So if one of these people had measles, it could go through these, but then the measles is going to die out. In other words, they're never going to get measles. Small groups of people are not going to get infectious diseases because it can't survive. So then, that's their diet, and that's why I had to keep moving. But only quite recently, 10 to 15,000 years ago, we had a major change in our development. We learned to grow vegetables. And when we learned to grow vegetables, we could then no longer be hunter-gatherers. We could grow enough food to last us all year round. Note the beginning of clearing the bush, the beginning of environment change. So we started living and getting closer to insects that we're displacing, and we grew vegetables. So this 10 to 20 people grew to several hundred, and with time, that several hundred grew. And measles, for instance, which is very infectious, 16 to 18 people, must have a population of about 500,000 people to sustain it. Otherwise, the measles virus dies out. So it wasn't until we grew vegetables that we could start having a population of that size in the early cities. And once we'd grown vegetables and formed towns shortly after that, we started farming animals. So we were a lot closer to a lot more animals. And then it became easier for us to catch most species, pathogens, species specific. They do not cross the species barrier. But things like influenza, chooks may have almost 200 different species of influenza in their gut flora, and 3 times per century, one of those comes over to cause a pandemic. Similarly with measles and the rinderpest. Once there's a large number of people, and we spent a lot of time with cattle, then we were able to start catching. So infectious diseases have not been amongst humans for millennia. They have only been primarily in the last 10 to 15,000 years, whereas our 500 to 2,000 good, healthy gut species that we tend to find yuck is essential to our immunity. So we know humans have been plagued with famine, infectious disease, and war. But infectious diseases relatively recently, and we've largely mitigated that, largely with vaccinations. More people die of obesity now than starvation, and war, there are fewer people per 100,000 killed now than ever been before. So all bugs are bad. I'm just going to race through those. We've been, so Black Death, Yersinia pestis plague, 75 to 200 million deaths. Post-Columbus America reduced 90% of the population. Spanish flu, 50 to 100 million deaths, etc., etc. Dreadful, dreadful things. Many of them come from animals, and they have kept emerging more and more. And the bigger our population is, the better it sustains infectious diseases. Causes nearly 1 in 5 deaths in the world. Most of them come from animals. Most of these new diseases come from animals. 70% newly recognized pathogens, zoonoses, including the measles virus, which, as I said, came about the year 1000 AD. 1100 AD was when measles first came to humans. And we get we keep seeing all the new bugs. And so there's about 20 new emerging infectious diseases every 20 years. They're ongoing. And some of them don't go around the world. And some of them are regional specific. Some of them are re-emerging, and some of them are new. We're not going into the cause. I say it's 7 minutes past. For those that can go, just go. I'm going to just look up, okay, that's the exact question. But that hepatitis B with waning serology immunity is interesting. And a problem with students going into study and having to have serology levels over a certain level, and they have to have a booster. I agree, it's nuts. Thanks, Marie. The last time I looked up the vaccination New Zealand handbook, it's about 2 years ago now, because I had to advise people to follow the New Zealand guideline and do this. But all the overseas ones now say this. Then they updated it. I think it was about November, year before last, they updated it. But they've only updated half of what they said. So one part of the manual, New Zealand handbook, said, no, you don't have to. But the other part, a few pages on, said you still did have to. So I agree, it's a trouble. But you can guarantee somebody, if they've had the full 3 shots, maybe if they've had documentary proof of it, that could help the case. Infectious diseases receded in the 20th century. Antibiotics helped again, but then towards the end of the 20th century, they started increasing again because there's more people closer to animals. We've changed more of our environment more and more, and so we're getting more exposures. So up, there's all those on the left that are increasing. Going down, smallpox, we wiped it out. Some of these others going down. Measles was going down, but we've got a bit slack with it. So I'm going to, because of the time, I'll just go to this. And so the closer we get to these, the more, and you'll see I've slipped on measles to this one here, did that this afternoon, because that's going to be coming from the cows, if you like, originally. All these different animals, they have their own diseases, and remembering the viruses, as they generally are, but sometimes bacteria, are struggling for their survival too. So if they can adapt or mutate, they will maybe eventually get through to humans. They may get through to humans. Then we have to think about, not very nice to think about it, but with emerging infectious diseases, we have bioterrorism. And so with vaccination, which is what this talk is all about, Edward Jenner, Nellie Nelms there, who's the milkmaid, who a farmer had noted that only though when smallpox swept through the villages, this is 1700s, the farmer noted that the milkmaids never died. And smallpox would have a 30 to 50% mortality rate, but 0 in the milkmaids. The farmer noted that, so Edward Jenner scraped off the warts from the milkmaid who had milked the cows, and the cows have warts, which is a similar pox virus, and put it onto James Phipps's arm here, scratched it and put those Nellie's, I think the cow was Daisy that Nellie milked, and unusual name, isn't it? And so scraped the wart onto James Phipps there and put him into a smallpox ward, and he didn't die. That shows you a couple of things. One, that ethics has changed somewhat, as number one, and number two, it worked because James Phipps did not catch smallpox, and Edward Jenner has been credited with saving more lives than anyone else. So vaccinations have been amazing. If we do measles vaccinations sufficiently amount, we might have a 99% and not have any outbreaks at all. There are still the naysayers about vaccines, and those that should know better make the biggest fuss quite often. but it is a serious discussion to have, and we need to have it. As I said, when people get given antibiotics, and we now have half the number of species that we had before antibiotics. Since 1943, we've lost half of our species. So I'm just going to come over, although we tend to think when we have a wash, we get rid of all those bugs. We get rid of the newly arrived ones, including if we've got influenza or measles and coughed onto our hands. But we still have all our hollow biomes, if you like. We are coexisting with those, except we've lost half the species and our immunity. The vaccinations do not work as well when our microbiome is not fully stocked. So we can get all of these in the PDF when it comes. I'm cutting out a whole lot. So our microbiome is key to it. Although public health primarily relied on vaccines, we need a full microbiome, microbial mass, to have those vaccinations and our immunity to work well, and antibiotics work against the microbiome. So we get a lot of our microbiome from birth, vaginal birth, and breastfeeding. But all bugs, infectious diseases may come from the environment. We know that eating dirt is good for us. We haven't yet learned how much of which types of dirt are critical. Clearly, if there's a whole lot of salmonella on there, they may be in trouble. But we know what goes around comes around. Sometimes people, I find that fetal and fetus, I find it bizarre. Having said that, HeLa cells for virology, HeLa, I don't know if you probably haven't heard of it, H-E-L-A, is a cell line that's used in all virology labs. They're called HeLa cells. Originally, they were from a woman's aggressive cancer 100 years ago or 80 years ago or something, and that's her initials, HeLa, or acronym of her initials. So HeLa cells are still used. It just happens to grow virus as well. So they're that one. So I'm just finishing up now. PPE, does it work or not? Well, for influenza, yes, works about 90–95%, much better than the vaccine actually. So we should encourage vaccinations for a start for influenza, but they're not that flash. The truth is 20–50%, or 5–50%, maybe 60% in a better year. But as soon as we've vaccinated as many people as possible, then if everyone with a new cough to them wore a mask, would stop the influenza spread and all the other respiratory viruses. But measles, reduce but not stop, reduce but not stop. So, and ages and stages, no, they're not going to get measles. And they're grumpy, even though it says happy anniversary. They learned once that, what have we learned? We've learned, cleanliness is next to godliness. I just like this. Oh no, I was going to put this up next. I like this one. At the age of 65, my grandma started walking 5 miles a day. She's 92 now. We have no idea where she is. It's got nothing to do with measles, but I just like it. So there's plenty of room to be pessimist, but we're not going to get more than 200–300, perhaps 400 at absolute most cases of measles, but it's a dreadful, dreadful illness. And we wish to, hopefully it doesn't get above 200. So we can see what's coming if we don't vaccinate. And they are vulnerable. They are vulnerable unless we happen to get rid of measles from the world, which we're not going to for a long time. We might get rid of polio if we keep trying extra, extra hard, but measles got a way to go. We need that 95% vaccination rate or more. So thank you very much. I hope that's been worthwhile.